All righty, it's a great day, y'all. In fact, you might say it's a good day, and you'll see why why in a moment. Um, yeah, very, very excited. We have the one and only Prof. Rez back with us on Friday, and I'm gonna try to keep him silent as silent as possible, because we have a lot of people to thank and welcome. Uh, the first being our very own Zachariah, who's scribing today. So, Zachariah, I'll hand the mic to you to say a hello.
Hi everyone. I'm Zakaria. Looking forward to the case today. I haven't had a Friday VMR in a few weeks as I was moving, and yeah, excited to get back into it.
We're very, very happy to have you. By the way, Zachary, you should say a lot more because I think we have a couple hours today. I'm kidding. I'm kidding. Thank you for hanging out. Lyra, thank you for doing the teaching points today.
Hi everyone, my name is Lara. I'm a medical student from Russia. Very excited for the case.
Amazing. Well, hey, from South Africa to Russia to all the way, actually right down the road. Our case presenter today is somebody whose name you might have heard about here or there, especially if you're in the CP Solvers Academy. But we're very thrilled to have Uttara here. Maybe I can hand the mic to you to share a little bit about yourself and perhaps expand on the on how you are intimately related to the CP Solvers Academy.
For sure. So, hi everyone. It's really nice to be here today. Thank you so much for having me. I am an infectious disease fellow at Stanford and have a real interest and passion for all things ID and global health. And I've been a long time kind of peripheral fan of CP Solvers, especially because my husband is Mark Heslin, the one and only. So you've probably seen him around on all these VMRs and the podcast that just came out. Everyone should check it out. So I'm really excited to be kind of following in his footsteps and joining today.
We are so, so happy to have you. I think the power couple of Mark and you is just amazing. We get a little bit of an insight just knowing Mark of just how awesome you both are. And so we're very, very happy to welcome you here. Prof. Rez reminded me that I should keep my flattery to a bare minimum. So I will stop there and hand the mic to him.
Good morning, everyone. So excited to be back. Looking forward to tackling this case with Robbie. It's very nice to meet you.
Likewise.
Awesome. All right. Ready to rock and roll whenever you are.
Okay, great. So I'll start with the first aliquot. So this is a 73-year-old man who presents with 4 weeks of fatigue and bilateral lower extremity swelling.
Yeah, I think this is a, by the way, how do you pronounce your name? Is
Yeah, so
Uttara?
it's pronounced Uttara.
Uttara.
Yes,
Uttara.
you got it.
Awesome. Well, this is, first of all, thank you for being here and presenting despite all your responsibilities as a fellow. And you see, it's okay when I flatter the presenter, but it's not okay when Robbie flatters. I just want to make that very clear and for that to be on the record. I think this is a really good stopping point because when you see the chief concern of swelling and fatigue, what the clinician does is decide which one to anchor their thinking around. And the truth is, fatigue is very nonspecific. And all of us experience fatigue if we have one night that we don't rest well. And it's really surprising. I've thought about this. Like you lose one night of sleep and the next day you're grumpy, you're irritable, you don't have energy, just one night. It's just fascinating. But lower extremity swelling, that has more specificity than fatigue. Though, if we're being honest, lower extremity swelling too has a very broad differential diagnosis. And you make more progress by understanding that it is bilateral as opposed to unilateral. And of course, if it was asymmetric, that may add a different dimension to this case. But whenever you have lower extremity edema, before you rush to think about the 4 organs, the heart, the liver, the kidney, and the thyroid, you should step back and realize that most of us will have some swelling in our legs as a consequence of venous insufficiency. Anyone over the age of 50 will have weakened venual valves, and that will lead to edema. So in reality, the question really here is that fatigue really shortness of breath and the patient is sort of conveying it as fatigue? Because if we then have shortness of breath and lower extremity edema, then all of a sudden the heart gets prioritized as the site of pathology. But I actually don't want to spend too much time here because I think it would be a mistake. It's just realizing fatigue is nonspecific. Think about the lower extremity of edema, and that really should guide your next steps and try to get more clarity into what fatigue means to the patient. Back to you, Thora. I don't want Ravi to say anything.
Perfect. Awesome. Thank you for that. So I'll move on to the next aliquot just to get a little bit more information. So we ask him a little bit more about this fatigue. He says that he's just generally been feeling off lately, but has been more pronounced in the last 4 weeks with the accompanied lower extremity edema. He has no other clear symptoms, including shortness of breath, chest pain, orthopnea, or PND. He notes some occasional nausea and diarrhea. These symptoms don't seem to be triggered by anything, including any food. He has no abdominal pain. The symptoms really come and go. He's not had any associated hematochezia or melena. His past medical history is notable for aortic stenosis, for which he had a TAVR in 2023. He has a history of heart failure with preserved ejection fraction, type 2 diabetes, and hypertension. His current medications include metformin, empagliflozin, atorvastatin, and amlodipine, and he's been taking all of his medications regularly. He has no known allergies and no relevant family history. So just some social history to get to know our patient a little bit more. He lives in the Central Valley in Northern California. He has not traveled outside the country in over 30 years. His last trip was to Italy with his family. He's not currently employed, but used to work as an electrician. He recently decided to adopt what he calls an alternative lifestyle with his wife, where they packed all their belongings, rented a truck, and have been traveling around California for the past 4 months. They've been bathing intermittently at rest stops. He has had no dietary changes in the last 4 months, but says he generally hasn't been eating very healthy foods because of this kind of road trip, eating things with a lot of salt. He doesn't smoke cigarettes, does not drink alcohol, and has never done any recreational drugs. And so I'll stop there.
Can I make a quick interjection? Robbie, the dietary behavior is like Prof. Rez in the last couple of months.
Prof Rez has been sending me so many pictures of pepperoni pizza. What are you having right now, Prof Rez?
Pancake with syrup and butter.
Live your life good, Prof Rez. By the way, you still have one interjection if you need it, because you didn't interject because I didn't say anything. So you still have one for the rest of the 45 minutes. Anyway, I'm so happy that we have a case like this, because I think that for the for the team to see, for everybody listening to see just how an ID doctor gets a review of systems and an exposure history is unreal. And so I think it just took me back to intern year when I would sneak at the ID note and really extract that very rich social history. And I think it has to influence what we're thinking, especially if we start to build the case for an infectious syndrome. And of course, with you being here, I think we're biased in that direction. But I think you ask yourself, is there a robust case for an infectious disease? And I would say based on the foreground, maybe not, but based on the background, almost certainly. And let me just try to make that a little bit more readily apparent. So once we start to understand that this fatigue is not just an innocent bystander, that it really has taken grip of the patient for so long, almost a month, we realize that what Prof. Rez was essentially telling us, that fatigue can just come and go, you don't sleep good. The fact that the need to invest significantly in fatigue is certainly not something that we do on a daily basis. But when somebody tells you he's been gripped with fatigue for 4 weeks, especially somebody as active as you just described, I think it's hard to ignore it. And in fact, I think we look for it on the physical exam when we see that that thing that is so human about looking at another person who looks exhausted and tired. And I suspect we're going to do exactly that. And so now that we're paying attention to the fatigue, you ask yourself, well, how does the like real legit prominent fatigue help influence the calculus for a patient who has lower leg swelling? And I would say it does in two ways. The first is you want to try to establish if the fatigue is exertional at all, in which case you would land significantly on the heart because the kidneys and the liver don't care when you're exerting yourself. But if you find yourself living in non-exertional fatigue, you'll remind yourself that metabolic perturbances are the heart of fatigue, really. The hyponatremia, the liver injury that really cause people to feel having lack of energy. So I think with the history, you really establish that there's not a prominent exertional component to this fatigue. And so that helps you say, wait, is there a problem in the liver or is there a problem in the kidney as a priority? But with that in mind, you then get the past medical history. And the past medical history here is a game changer. Because whenever somebody has prosthetic material in their cardiovascular system, and all of a sudden the range of possibilities of fatigue are altered dramatically. And for that, folks in the academy will remember this reflection about fatigue being fundamentally a problem in the blood. And unfortunately, we don't have enough time to really dive into that. But if you take my word for it, that like the way we diagnose fatigue, we really diagnose people is we test their blood for something, test it for low sodium, test it for low hemoglobin, test it for high creatinine. And so when you have something fundamentally in your cardiovascular system as prosthetic material, all of a sudden, now you have to say, okay, is this the blood-based problem that is causing the fatigue? And then naturally, by extension, is this the blood-based problem that's causing the patient's lower extremity edema? So I think that this case would have proceeded with a very gentle tempo to try to figure out what this patient has in a non-emergent manner. But now, just with that prosthetic valve, all of a sudden, this patient, no matter what vital sign he has, whatever you say in the next aliquot, he needs blood cultures. And Prof. Reza and I have learned that lesson in a very humbling way on RLR CP solvers, not here in VMR as far as I remember. So I'll just leave it at that. That fatigue, most of the time you ignore it. Here you can't. It's really heavy for the patient. Overlaid with edema, if it's non-exertional fatigue, it's metabolic edema from liver and kidney disease. If it's exertional, it's cardiac disease until proven otherwise. But we don't just make progress in clinical reasoning by the foreground. The background influences what we do. So even though this seems to be non-exertional fatigue, the fact that he has a heart problem, especially a prosthetic valve problem, really has us saying, yeah, we'll get an easy insight into the liver and the kidney through blood work. But we need to not lose sight of the fact that the patient has a aortic valve issue. So I'll leave it at that. I'm curious, Prof. Rez, how else you're analyzing it and then what your mind authentically did with the exposure history here.
Oh man, Robbie, that was so beautiful. I've never heard you talk about fatigue like that. And you're absolutely right. Any symptom that persists for a while needs to be taken seriously. And honestly, with the background data, I really appreciate that Uttara, grab that information, but I'm not incorporating it into solving this case because it would be inauthentic to the process. So it's something that we'll track and we may have to visit back. But for now, my main goal is to do that physical exam and to see if I have jugular venous distension, is there liver disease, and then make my way to the labs to see where I can pinpoint the site of edema to. Uttara, back to you, my friend.
Amazing. Okay, so I have some vitals for you. His vitals on arrival, his temperature was 97.3 degrees Fahrenheit. His heart rate was 80. His respiratory rate was 16, and his blood pressure was 167 over 100. On exam, he appears comfortable. He's lying in bed. His pupils are equal, round, and reactive to light. We took a look at his mouth. He has normal dentition. His heart rate is normal with a regular rhythm. No murmurs are heard. No JVPs appreciated. His lungs are clear to auscultation bilaterally. He has bilateral lower extremity swelling with 2+ pitting edema, with scattered petechiae noted on his bilateral shins. He's neurologically intact, alert and oriented, moving all extremities spontaneously. In terms of his labs, his white blood cell count is 2.8 with a ANC of 3.4, which is normal, a lymphocyte count of 0.38, which is low, and then normal eosinophils. His baseline white blood cell count is around 8. His hemoglobin is 7.5. His baseline is around 12 with an MCV of 91. His platelets are 16 with a normal baseline. His BUN is 63. His creatinine is 4.17 with a baseline of around 1. His AST is 33. His ALT is 20. His alk phos is 160. His total protein is 7.9. His albumin is 3. His total bilirubin is 1.1. The team ordered an NT-proBNP, which was elevated at 6,624. And they also got a UA, which shows 3+ protein, trace glucose, trace ketones, 3+ RBCs, rare bacteria, and no pyuria. And that's the end of the third aliquot.
Wow, if you talk about a pivot point. So we, by the way, Robbie, I got some maple syrup on my keyboard and it's like so icky and like my fingers getting stuck. Anyways, back to the case.
Wow. That's my response.
You know what your last discussion reminded me of? I know you don't watch TV, but Curb Your Enthusiasm is by Larry David. And he has an episode where he emphasizes where someone makes a comment. It's like, hey, Robbie, you look really much in shape. Having said that, and then you say something completely like opposite. So like having said that allows you to pivot. That's what you kept on that aliquot. You kept like saying something. You're saying, but having said that, and then you would go down the direction.
Guys, didn't you miss him? Didn't you miss him? Welcome back, Crawford. So happy to have you.
Listen, we have so much data here, and maybe what I can do, Robbie, just start with the physical exam and then hand the mic to you, and we can dance back and forth if needed from there. I think, you know, what Uttara did us a favor here, by the way. She was like, this guy has lower extremity petechiae. That is gravity-dependent extravasation of red blood cells. But you have to realize this, when you're starting out as a clinician, you have to be able to actually diagnose the petechiae. And in order to do that, what Uttara and her team saw were pinpoint red spots on the shin. And then when they went and pressed on it, they saw that it doesn't blanch. And that's how you actually arrive at petechiae. And a really simple way of thinking about petechiae is stepping back and say you're having bleeding into the skin. That's really what petechiae are, bleeding into the skin. And so then the exercise becomes, why are you bleeding? And when you approach it like that, it becomes really straightforward. People bleed because there's an issue with the platelets or the clotting factors. That's like one arm of the hemostatic system. And here I have to quickly look at the labs and you see, oh, the platelets are 16,000. So the patient is vulnerable to bleeding. But remember, to have spontaneous petechiae is rare. You want to make sure that this patient doesn't have any compression stockings on or anything tight around the extremities, because it has to be a two-hit hypothesis, in my opinion, if it were the platelets causing the bleeding, meaning that they have compression stockings and they're thrombocytopenic and therefore have petechiae. So it's going to be important to clarify if there's any trauma to the lower extremities. Then we're going to definitely want to see the PT and the PTT, because that's also part of the, hemostatic systems. But I think in a case like this, back to Robbie's point, that's been going on for a month, you really have to step back and be like, well, is there something going on at the level of the vessel? So we talked about the blood. Now we're at the level of the vessel. And the level of the vessel, it just breaks down into, is there something inflammatory happening or non-inflammatory? And this is where that term palpable purpura originates from. Because purpura are just a lot of petechiae together, you get purpura. It's just based on the size. And if you have palpable purpura, it means the blood vessels are inflamed and you can make so much progress. But how the heck do you determine if someone has palpable purpura? You close your eyes and see if you can feel the contour of the bruised lesions. If you can, then you have palpable purpura. But just very briefly, like the non-inflammatory causes of vasculopathy include stuff like aging. When we age, our vessels are weaker. And so we're at risk of having bleeding into the skin or petechiae. amyloid, scurvy, we're going to put those aside. We really want to think about, in my opinion, two things. One is either an inflammatory cause of vessel injury, and the second is trauma plus thrombocytopenia. I think those two are leading hypotheses in this case based on all the other data that we see. And for the inflammatory causes, this is also very simple to approach. You either ask the question, is it some small vessel ANCA related vasculitis? This goes into MPA, EGPA, drug-induced vasculitis, or is it immune complex mediated? So is it posse-immune or immune, just like what we would do at the glomerulus, we're doing at the level of the skin. And for the immune complex mediated, a prototypical example would be something like endocarditis, but lupus as well. Lupus can cause a hypocomplementemic vasculitis. So I think, Robbie, I'm going to pass the mic to you, but I just want to emphasize, it's really important to understand petechiae. It's really important to say it's gravity-dependent petechiae, because we're prioritizing the small vessels. And here it's either thrombocytopenia and trauma, or it's inflammatory, which then you break down into immune complex or posse-immune for the cause of the vessel injury.
Professor, I think that's absolutely poetic. And I think that I'll tell you, to layer on to what you just said about the labs, I've never seen this laboratory pattern before, ever. This combination of things. And I think it's painting a very, very beautiful story. So all I'm trying to do, I'm not going to offer any actual diagnoses at all. I think that's impossible. But what I'm going to try to make an argument for is the theme that Prof. Rez is building. So we started off with the HPI, where we said fatigue equals blood problem, aortic valve as a risk factor. And then here we are, as Prof. Rez is saying, he's saying is either the blood or the blood vessel. So we're really worried fundamentally that there's something happening in the cardiovascular system of this patient, as evidenced by the fatigue and as reinforced by the petechiae. And I should be just to explain what I mean by cardiovascular, I'm literally saying that there's something wrong in the patient's circulation. And so let's analyze the labs in that context. And if you first start with the patient's urine. So the patient's urine is a problem with his circulation. Why? He has 3+ protein. That tells you that he has something wrong in his glomerulus. What glomerulus? What's the nature of that glomerular problem? Well, he has a lot of red blood cells. He has kidney injury. And he's hypertensive. This is glomerulonephritis until proven otherwise. How do you make even more progress towards glomerulonephritis? All you have to do is to listen to the most recent RLR, where we talk about the combination of AKI and hematuria. AKI plus hematuria that is painless, meaning the patient doesn't have a kidney stone or bladder outlet obstruction, is basically glomerulonephritis. And of course, you can take that leap with even more confidence when you see the extrarenal manifestations of capillary leak in the skin. What is another blood vessel problem this person has? His heart's not working. For two reasons. He has a risk factor. He has aortic stenosis and a TAVR, and his BNP is through the roof. The predictive value of a BNP in this person is through the roof. So we're saying that there's almost as clear as mud evidence that this patient has cardiovascular disease based on what he said, based on what his background is, based on his physical exam, as Prof. has eloquently outlined. And now we've localized the lesion to be in the kidney, glomerulonephritis, and in the heart. And if you listen to the most recent RLR episode, Prof. brings a really, really cool case that illustrates the following point. If you have glomerulonephritis and cardiac disease, the patient has endocarditis until proven otherwise. And you don't need to think harder about glomerulonephritis with a cardiac signature than that, especially when the patient has a prosthetic valve. So you look at this data point, anytime you see that UA with that BNP, you have to exonerate endocarditis every single time. And so here for me, I'm saying, okay, this is an endocarditis until proven otherwise. And then I run into a massive, massive block. How many patients with endocarditis have I seen that have pancytopenia? The answer is 0, which is why I'm really excited for the remainder of the 30 minutes, because either then this isn't endocarditis, Maybe I'm completely wrong. Or this is a profound clue to the nature of this patient's endocarditis. And I will be frank with you, the case for endocarditis is so robust based on the history, the background profile, and everything that is saying, and everything they're saying here. I want to acknowledge maybe I'm probably subconsciously biased by the fact that we know we have an outstanding ID fellow presenting the case. That's probably influencing my thinking. But I'm asking myself, okay, how does pancytopenia influence the probability of endocarditis? And I think in order to understand that, again, a really a helpful schema on RLR-CP solvers is the 4S schema for pancytopenia. Systemic, acute systemic issue, not the case today, not an acute systemic disease. We're talking about tick-borne disease as an example of an acute systemic disease. That's not happening. Substance, like alcohol or vitamin B12, substances don't cause glomerulonephritis. That's gone. Stem cell disease does not cause a prominent extra bone marrow signature. So we're left with the last S, space occupying. Whenever you think space occupying, you have to think granuloma and cancer. Now, can we overlay cancer and glomerulonephritis? Yes. Can we overlay, can you overlay cancer and endocarditis? Yes. Beautiful pathophysiology of merantic endocarditis. But merantic endocarditis doesn't usually cause glomerulonephritis. So now the question is, can we overlay granuloma and endocarditis? And the answer is absolutely yes. The whole world of granuloma and endocarditis is the world of culture-negative endocarditis. That's basically what that space is. So this is getting ahead of ourselves. But I will tell you what the appropriate place to be is, in my opinion, is this case is screaming endocarditis. And you have to ask yourself, how can I merge endocarditis with pancytopenia? I think the case is so strong that I would empirically treat the patient after collecting 3 blood cultures with vancomycin and ceftriaxone, and then pursue the possibility of endocarditis very, very vehemently. And now I think is the time. If the cultures become positive, you have an answer. If they're negative, now's the time to go back and ask Prof. Rez, hey, what about that exposure history? Where does that take us? So I think this laboratory pattern is beautiful, and I'd love your take on it, Prof. Rez, and what else you're doing with it.
Dude, only if you had stopped one sentence short of what you just said, it would have been the beautiful layup. Look, beautiful pass. Now we have to go to Prof. Rez to talk, and then boom, we'll edit it and we'll put it on YouTube. Robbie, I think your discussion is stellar. One question I have for you before I even comment on like the background data, because I think it's a moment that gave me goosebumps on a recent RLR that I haven't published yet because I've been delayed. What about, you were discussing that case of a patient with a GN, and that patient was normotensive. And you said, Reza, maybe you tell me, like, what did that make you say? And I really want to ask, like, how does the hypertension influence that hypothesis? Is it one of those things, if it's there, you can't really draw any conclusion, but if it's not there, it prioritizes?
I can't say it any better than you, Prof. Rez. That's perfect.
Yeah, so
I can sometimes be brief, Prof. Rez. I hope you know that sometimes.
What Robbie taught me was this. It was a case of a GN. The patient was normotensive. And he said, Reza, the way I can reconcile this, if there's something on the valve, like endocarditis, affecting the blood pressure. And I thought that was so well put. But here, to Robbie's point, I think, based on his discussion, I would actually add doxy, just based on Robbie's discussion. Maybe I wouldn't have done that in real time, because we are now really prioritizing a culture negative endocarditis because of that pancytopenia. I think you said it so brilliantly, like some kind of granulomatous process. And now you go look at his history and you see that he's, in the Central Valley of California. So he's at risk of coccidiomycosis. You see that he's traveling and but coccidio and endocarditis, I don't see the link there. You see that he's bathing and traveling. He might be exposed to lice. So then you wonder, could this be Bartonella quintana? And this was formerly known as trench fever. And it's actually Bartonella is the most common cause of culture negative endocarditis. most common cause. And so oftentimes the two species that we worry about is Hensley and Quintana, Hensley being more related to cats, but it's never the cat's fault. It's actually the human's fault, not the cats. Remember that if you take one thing, I have 2 cats, never blame the cats. They're beautiful. But in this case, where there is no cat exposure, you would prioritize Quintana, but then there's other organisms like Coxiella. And remember, Coxiella, you don't need to be exposed to the farm animal. Just go look at Rabih's NAGEM, CPS. I'm forgetting the title of that, but it was basically a guy traveling with no farm exposure, but you learn that the spores of Coxiella burnetii can be carried, for miles. So you don't actually need that exposure. Coxiella. Brucella is another example of culture-negative endocarditis. So Rabih, what this background data does for me, it actually, with the background data, the pancytopenia, and the point that you made that you've never seen that with endocarditis, I'm in that space of like, is this granulomatous infection, granulomatous invasion, and then just post-endocarditis immune activation leading to glomerular nephritis. So I would just add doxy, but I'm not yet there to be like, it must be endocarditis. I'm open to this case being something completely different. But if you ask the question of all these data points, which is the most, because remember, we started from the very beginning. Fatigue is not specific. Fatigue is not specific. Edema is more specific. Here, where would you focus on? You would have to focus on the glomerulus. And so the final answer must explain that. But recognizing that sometimes you can get IgA nephropathy that can lead to glomerular injury that's just post-infectious or post-immune activation related. And so then it's either immune complex, ANCA, or anti-GBM, but anti-GBM and ANCA don't explain the marrow. So here you would have to prioritize an immune complex mediated cause of GN. And there, I think you run into a trap because you're like, oh, could this be lupus? I mean, with lupus, you have Limben-Sachs endocarditis, and you can certainly get cytopenias, but the post-strep GN and endocarditis, pancytopenia is not part of it. And that's where I think the granulomas really becomes prioritized. Let me pass the mic to you, Rabih, just to sort of summarize where we are as a couple. I know Uttara and Mark might have a special relationship, but they don't know what the RLR relationship is.
We're at the point where you are telling me all about your maple syrup disasters, Prof. Rez, as a couple, which I feel very, very, very grateful for. Yeah, I think impaired treatment is very, very key. I think I love the point about adding atypical coverage as well, or granulomatous coverage as well. That's awesome. I want to make sure you make it on time for your golf lesson, Prof. Rez, so I'll leave it at that.
Right, awesome. Okay, so more information. So we get PT, PTT, and INR as requested, which are all normal. We get a peripheral blood smear, which was unrevealing. Hemolysis labs, which were all negative. We send for B12, copper, folate, and iron studies, which are all normal. The team gets a UPCR, which is 1.52. They also get a TTE, which shows an ejection fraction of 55%, mild concentric LV hypertrophy, moderate LV diastolic dysfunction, normal RV and RA size and function. It notes that he status posts a TAVR with normal valve function, no MR or TR, and there's no prior TTE for comparison. We get some more labs, and a P-ANCA comes back positive. C-ANCA is also positive. MPO is greater than 8. PR3 is 4.2, both positive. An anti-GBM is negative. C3 is 50, which is low, and C4 is 9, which is low. An ANA is 1 to 80 in a speckled pattern. Anti-double-strand DNA is negative. Anti-histone antibody is positive. Anti-SSA and SSB is negative. RF is positive. Cryoglobulins are negative. 3 sets of peripheral blood cultures are drawn, which all have no growth. He's hepatitis B immune, hepatitis C antibody negative, and he's HIV negative. So I'll stop there.
I just want to, I really just genuinely want to thank you for this unbelievable case you're presenting, because I think that the number of stories and lessons we can impart are so many. And I think I'll leave the juice of this aliquot to Prof. Rez and just comment on the TTE and then ask you to comment on everything else. And I think the TE is a test here that is really asking, does this patient have endocarditis? And I think that the way to go about really asking yourself what value that test brings is all about your pretest probability. So in a low probability situation, a TTE might be an outstanding test to exclude endocarditis, just like a D-dimer with a pulmonary embolism. And just like a D-dimer with pulmonary embolism, anytime that your pretest probability is anything but low, you have to recognize that the TTE has very many holes in it. And those holes are especially prominent when a patient has a prosthetic valve. So the sensitivity of a transthoracic echocardiogram to exclude prosthetic valve endocarditis is very, very difficult. In fact, the test that you may all know as a backup test, TEE, may also have significant flaws in the context of prosthetic valve endocarditis, to the point where advanced radiological imaging in the form of a PET CT scan is another tool that is considered in the toolbox for prosthetic valve disease. So based on the fact that the pretest probability of endocarditis is not low, and the fact that detecting prosthetic valve endocarditis can be very, very tricky, the TTE here and the lack of evidence of endocarditis does not sway the needle in any way, shape, or form. It just unfortunately pushes us to try to collect more evidence for endocarditis, which I think we can do through imaging, of course, but also seeing if there are any other clues to suggest this condition. Mike to you, Prof. Rez.
Yeah, Robbie, thank you for saying that. I love the PET CT for endocarditis. At the VA, for some reason, we're able to get PET CTs quicker than we can get MRIs, but we'll take it. I think, let me just say this. Everyone's wondering, does this patient have ANCA-associated vasculitis, right? Because the C-ANCA is positive, there's a PR3 that's positive, MPO. But you have to, there's two things that argue against ANCA-associated vasculitis, and actually prioritize an immune complex mediated process through activation of the immune system. And what are those two things? One is the pattern of the ANCA. Because remember, whenever you're obtaining ANCA, just ANCA positivity doesn't mean ANCA-associated vasculitis. And we do ANCAs in two steps. We first send, it's either C-ANCA, P-ANCA, and then we see and confirm with the more specific PR3 or MPO. But here you have both like MPO positive, PR3 positive. So that in itself, when you're getting both things be positive, should make you pause. Or if there's a disconnect, because when C-ANCA is positive, you expect PR3 to be positive. When P-ANCA is positive, you expect MPO to be positive. So that disconnect of both of them being positive should make you question it. The other reason you should question it is the complement levels. The complement levels are so valuable here because little immune, by definition, you're not activating complement, so you should have normal complement levels. So the low complement levels and the pattern of ANCA really excludes the possibility of an ANCA-associated vasculitis, as does the other findings here, like the pancytopenia. Then you might say, does this patient have lupus? Remember, that's where we're living. We're living, is this autoimmune anti-GBM or lupus? Anti-GBM is not a good pick. It's not a good fit for this picture. And with lupus, the AMA being positive, boy, 1 in 5 of you will have this type of positivity, maybe 1 to 40 titer. And the antihistone being positive, it doesn't do anything. So all those antibodies do for me, Robbie, is tell me that the immune system is activated, and the low complements tell me that there is immune complex deposition. And so now the question becomes, what is driving the immune activation? And I think if we can confirm this is culture negative endocarditis, all you have to do is go on RLR CP solvers. And let me just show you guys this really quickly here. I think it's worth just showing because it is gonna sort of elucidate stuff. But this is where we are. We're really culture negative, but we're not worried about non-infective. We're really prioritizing infective. And the most common cause is that they got antibiotics and then they got the blood cultures, which is right here. you're left with fungi and bacteria. And it's really the world we've been living in, guys. I think of all these granulomas, particularly Bartonella and particularly Bartonella quintana is the most likely culprit here. But regardless, you'll treat with doxy and there's no evidence in the lung, but if you get a PET CT, you might see if there's stuff happening in the lungs, then maybe you prioritize a spore that's been inhaled from the environment leading to disseminated granulomatous infection. But I think you start with doxy. I think you have to just say one more thing, that serology is okay for diagnosing some of these, especially if the titers are really high. But this is when I would actually send a Carius test, which is DNA that's been released from the organism. And that Carius test is probably going to confirm the diagnosis. Now that you have culture negative endocarditis, I think here it would be cost effective and high value if you have access to the Carius test. But Robbie, any other things to layer on? I think we're really in the world of infection, and I think we're in the world of disseminated granulomatous infection, and I think we're in the world of Bartonella quintana.
I think it's absolutely superb progress. I think, yeah, in terms of next steps, getting a very good look at that valve is going to be very, very key. And then, as you said, following up the microbiology. Alrighty.
Awesome. Amazing discussion. Okay, so the team decides to pursue a renal biopsy, which shows active glomerulonephritis with crescent formation. Based on light microscopic appearance, this appears to be posse immune. Moderate immune complex deposition in the mesangium and subendothelial space. They also get a bone marrow biopsy, which shows erythroid hyperplasia, no evidence of morphologic dysplasia, cytoplasmic vacuoles, or infiltrative process. So given the biopsy and serology findings, rheumatology was consulted. The patient was actually started on rituximab and prednisone for ANCA-associated vasculitis and glomerulonephritis, given the renal biopsy findings. The patient continued on immunosuppression for 1 week. However, his creatinine continued to worsen, and he eventually required hemodialysis. So the next aliquot will reveal the diagnosis.
I'm going to pass the mic to Robbie, but Robbie, how fascinating is this, my friend? Like literally, we just recorded this episode. And like you now see how common of a theme it is. And I'm just, yeah. And I just want to go on record that I wasn't the one who said give a gram of methylprednisolone in this case. But Robbie, I really want to ask you a specific question. Like, why do you think this happened here? Like, yeah.
Oh, Prof. Rez, oh my gosh, all I will say, I'm sitting next to my wife, who's a future rheumatologist, and she just sat there and went, yeah, I think, Prof. Rez, I think, yeah, this is a very, very tricky case. And I think, as I said to you, for me, I think this case just goes to show what the value of being a general internist is, and being a person who is able to actually see the small gaps in our experts' knowledge, which are never about their domain of expertise, but usually about accompanying organs. So as we talked about, I think a nephrologist may not be able to understand cardiology like a cardiologist does, and a cardiologist may not understand nephrology like a nephrologist does. And that's where we, I think, have the ability to serve as a bridge. And I think the case for a culture negative endocarditis in this case is through the roof. And I think we've already made that case. So I'm not really sure. I would say the reason it happened is because the ANCA serologies are very, very misleading, and they have to be analyzed in the way that you just taught us how to analyze them. And so now I think the question is, well, what's the bug? And I think the base rate would be very, very suggestive of Bartonella for sure. And that would be where I would invest most of my energy. I think the counter argument to Bartonella would be that the propensity for Coxiella to love prosthetic valves would loom large. And so I would have a hard time being able to make an educated guess based on the fact that he really doesn't seem to have overt Bartonella risk factors, meaning that both Bartonella, Hensley, and Quintana have certain epidemiological features which he doesn't have, but his case is so classic for Bartonella in terms of the false positive serologies and the fact that it's the most common. But I think the fact that he's been driving around a lot, windows down, and has a prosthetic valve, has Coxiella being a very eager competitor. But I think we know what we need to do. We need to try to find the DNA for the organism that's doing it. And I think it really is a toss-up between those two, in my sense. Anything you want to add before we get to learn?
Thank you for the teaching point about Coxiella and the tropism for the valve.
You think it's time for an ID consult? All right, let's hear
Don't
it.
say anything else. Leave it at that. Time for an ID consult. Pause.
Thank you for your coaching and training, Prof. Fritz.
Okay, amazing. So the rheumatologist, kind of based on, his worsening symptoms, goes back and kind of looks back at the pathology and notes that, like you guys are saying, not only was there, PASI immune appearance, but also immune complex deposition. And so they finally ordered some infectious studies. They ordered a TPPA to screen for syphilis, which was positive with an RPR of 1 to 64. They finally ordered blood cultures, which were negative, 3 sets. Brucella antibody was negative. Coxiella antibody phase 1 and phase 2 titers were negative. We were then consulted at this point to further evaluate. So in talking more to the patient, he told us that his wife actually has a cat that had not come on the trip with them, so he didn't think to mention it. He doesn't remember any bites or scratches, but was definitely in close contact with it. So we send Bartonella serologies. His Bartonella Hensley IgG was 1 to 16,384, with an IgM of 1 to 256. His Bartonella Quintana IgG was also 1 to 16,384, with an IgM of 1 to 16. And then we did send a whole blood Bartonella PCR, which came back positive. So given our suspicion for Bartonella endocarditis, resulting in immune complex mediated and ANCA-associated glomerulonephritis based on the biopsy, we obtained a TEE, which didn't show any vegetations. We tried to get a PET, but unfortunately couldn't be coordinated. So we got a tagged white blood cell scan, which showed significant uptake around his prosthetic aortic valve, confirming our suspicion of culture-negative endocarditis. So we treated him with doxycycline and rifampin, dual therapy for 6 weeks, and then plan to continue doxycycline for a total of 12 weeks. So you guys nailed it.
I just have one comment because I don't want Robbie to aspirate. That's really great presentation. And Mark Hensley, I tried to block you on this when I saw the dog emoji greater than the cat emoji. I'm going to say to you and to Robbie, another dog lover, that cats are way better. That's the end of discussion.
You guys realize he muted himself, which is perfect because he's wrong.
I agree. I agree with that.
I have no words. This is an absolutely unreal case, and I was going to tell Prof. Reza that he should be disappointed in himself that he forgot to add the rifampin to his empiric doxy. But that's the standard he's setting. Honestly, I don't have anything to add, and I'd love to use our time to learn from you. And I'm curious, Uttara, when you were looking back at this case and we were taking care of this patient, what did you pick up on that you think we would benefit from, and what advice do you have to really sniff out this really tricky diagnosis?
Sure. I think what you said about, internist perspective was so powerful because, you guys started thinking about culture negative endocarditis right away, because you saw the ANCAs were positive, but noted these low complements and the pancytopenia and felt like, something just wasn't adding up there. But really, the infectious serologies were not sent until after this patient was exposed to, a lot of immunosuppression, and really towards the end of his case. So I think having that perspective would have been really helpful here. So I guess just like a few things that I kind of learned along the way during this case. So as you all were saying, Bartonella quintana, we really think about infected lice. And there's some reports of spread through cat fleas, but mainly this is through infected lice. And so we were thinking that, his biggest risk factor was living in this truck and bathing in these rest stops. It's interesting that his Hensley serologies also came back positive, very high, though he hadn't had contact with his cat for many months. But usually that's spread through, cat fleas and transmitted to humans through like a cat scratch. And he does have an outdoor cat, so that's always an important question to ask, like when you ask about animal exposures, are they indoor or outdoor, because they're at risk for carrying fleas. So as you guys said, it's one of the most common causes of culture-negative endocarditis, really Quintana more so than Hensley, but both, we see it in both. And it really has a proclivity to involve the aortic valve, which we think it did here. And obviously having a prosthetic valve is like a major risk factor. And it can be really hard to diagnose because it is culture negative. And really what we mean by that is it's a fastidious organism, so it can take a really long time to grow on culture. So we rely really heavily on serologies. And so when you look at the titers, his were sky high, so it really wasn't a question. But any IgG of more than 1 to 800 is really kind of diagnostic of endocarditis. And if you look at the modified Duke criteria, like that's what it'll say. And so this whole like association with glomerulonephritis, we know exists. It's been reported in the literature, and it's most commonly through like immune complex deposition. And we also know that there's this association with this false positive CANCA, though I'm not sure I fully understand that mechanism. We see it in other infections, like I think some people were pointing out in leptospirosis and even in HIV. So this is not uncommon, but like looking for other clues is really the key here. So the positive RF, the low C3C4 really telltale signs, along with the pancytopenia. But I think what makes this case really interesting was that, when you look at the literature, most cases of Bartonella-associated glomerulonephritis, when you look at the renal biopsies, are really immune complex mediated, even in the setting of a positive CANCA. In his case, it was immune complex, but also this posse-immune appearance. And there's like one case series that I was able to find, and really there's maybe 2 reported cases out there of posse-immune, so ANCA-mediated glomerulonephritis in the setting of Bartonella. This is the only case that I've ever seen in any of the literature where there was actually both immune complex and posse-immune. So this was a really, really interesting case, and nothing has been really described like this in the literature as far as I've been able to see. So yeah, it's a really, really great learning case, and you guys were obviously incredible and picked up on the diagnosis right away.
Well, I got to say, I think that your time is every person's time here is precious, but the truth is that yours is way more, given how busy you are and how you're pulled in so many different directions. So it makes it all the more special that you've chosen to spend this hour with us today, especially when you're giving us the gift of something that may have not been described in the way you're describing it. And I think we're so enormously grateful both for your time and the outstanding teaching that you just gave us. It lives on by itself. I'll offer one final piece of advice for those of you who are beginning to understand this space, which is that the most important blood test in a patient with glomerulonephritis is not the ANCA serologies or the ANA, it's the BNP. And if you find somebody has glomerulonephritis with heart failure, the default diagnosis is endocarditis until you prove otherwise. And I think that's the most powerful lesson for us to go the right way. And then you'll need Uttara's expertise to help you figure out what the bug is and if the patient has endocarditis or not. But for your purposes, if you ever see glomerulonephritis and there's a hint of heart problems, stop, no rituximab, no immunosuppression, and really exonerate endocarditis. And then refer to Uttara's outstanding teaching about how you might get there and why the patient might have it. But to take us home, Lyra, I'll hand the mic to you to summarize the learning.
Yeah, thank you so much, Dr. Utra, for this amazing case. I actually don't know what was better, the case presentation or the discussion. So we started off with approach to multiple problems. In such cases, we need to choose more specific symptoms to anchor our DDX on. And in this case, we were tossing between lower extremity swelling and fatigue. And it seems at first that lower extremity edema has more narrow DDX, but not quite. So when we were approaching the fatigue, we were asking ourselves if fatigue is causing dysfunction of a patient and not just discomfort. This means that we can't ignore this symptom. And then we also need to ask ourselves what fatigue means to the patient, because it can be represented by many mimickers, like shortness of breath, especially with the presence of lower extremity swelling. And then we asked ourselves how to localize fatigue. We need to ask the question, is this exertional or non-exertional fatigue? And if it was exertional, we would look more into the heart problems. And if it was not exertional, we would look more into the kidney and the liver. But the fatigue generally is a blood-based problem, which means that we should order blood cultures right away. Then we talked about our PTK approach, and for diagnosis, we need to see the rash that doesn't blench on exam, because it is represented by bleeding into the skin. And then we need to ask, why does PTK appear? First question we need to ask is, was there trauma involved? And if not, then look into blood and the vessel problems. For blood, we need to order platelet count, PT and PTT, to check for platelet or clotting disorders. And for vessel problem, we need to understand, is this inflammatory or non-inflammatory problem? And exam can help us in determining this by the presence of the palpable rash or non-palpable rash. Then we talked about the problem localization in this case, which was a pivotal point. We talked about proteinuria, which localized us to the glomerulus, especially with combination of hypertension and hematuria. We talked about the glomerulonephritis, and the combination of glomerulonephritis plus the cardiovascular disease means that we are talking about endocarditis until proven otherwise, especially in the patients that has a history of prosthetic valve. And then we talked about how the pancytopenia fits into this picture. We talked about the differential for pancytopenia, which includes 4S. And we focused our attention on the last one, which was basic pan lesion, which is represented either by cancer or granulomatous disease. And we also talked that pancytopenia reinforced our hypothesis about culture-negative endocarditis. We talked about the causes of culture-negative endocarditis. Most common cause for it is Bartonella, but we also can consider Coxiella, especially because this patient has prosthetic valve. And also Brucella can be involved in this process too. And then we were facing the dilemma of whether we're dealing with vasculitis or still infectious endocarditis. We talked that positivity of both PR3 ANCA and MPO ANCA, especially if we combine that with low complement levels. This means that we need to question this diagnosis and look more into infectious endocarditis. And we also talked about the value of TTE, which depends on the pretest probability, which means if the pretest probability is low, then negative TTE is good for infectious endocarditis diagnosis exclusion. But if it's high, then negative TTE doesn't move the needle too much, especially with prosthetic valve history. And that's it.
That is unbelievable. It's hard to imagine that you're yet to start your residency, yet you can approach this case, understand it, and then deliver it in the manner you just did there. That was unreal. I really, really am very grateful to all of you for this hour. It was a ton of fun. So thanks to everyone, with a special thanks to our guest Uttara. And we really, there's a lot of requests in the chat for you to come back and hang out with us. We know your time is very precious, but if you have the opportunity, we would be thrilled to have you back.
Thank you guys so much.
Bye.